Thank you very much for the introduction, and thank you for giving me this opportunity. And I think Mr. Paradigal still be with us, and nice to see you after a long time, Mr. Paradigal. And your talk was fantastic as usual, and I'm missing your everyday Friday morning teaching, just like for 1 year. And my talk is regarding spectacle prescription guidelines for myopia and astigmatism in children. Yeah, these are my contents. Most of the contents are covered by the previous speakers. And I'll start with developmental aspects and the definition of refractive errors. And what should I prescribe once I detect refractive error? And guidelines for prescription glasses, mainly for the astigmatism and myopia. And importance of talking to parents, as well as how to prevent this refractive and myopia. Actually, the one's ultimate refractive status, an interplay among corneal power, lens power, as well as axial length, and all elements are changing continuously as the eye grows up to age of 7. And the ultimate goal is emmetropia. That means the parallel rays of the light from distant object are brought to focus on the retina when the eye is at rest without accommodation. The bulk of this process is happening until the age of 7. Unfortunately, this is not happening in all children, and ultimately ending up in emmetropia, that is mismatch between axial length and refractive power of the eye. That means the parallel light rays don't fall onto the retina at the eye as rest, and we can categorize mainly 3 types: myopia, hypermetropia, and astigmatism. In myopia, these parallel rays converge into a point anterior to the retina, and we can further classify the myopia into axial and refractive. And hypermetropia, these parallel rays converge into a point behind the retina, and again we can classify it into axial and refractive hypermetropia mainly. And in contrast, astigmatism, what happens is that these parallel rays focus into 2 focal points rather than 1 focal point. And we can further classify astigmatism into irregular astigmatism and regular astigmatism. Regular astigmatism, again, we can classify it into with rule astigmatism and without rule astigmatism, as we all aware. Why is managing refractive errors is more important in children than adults? Because uncorrected refractive errors lead into amblyopia. And it may be ametropic or anisometropic amblyopia. Ametropic means both eyes having similar refractive error. Anisometropic means dissimilar refractive error. The refractive errors can't be prevented, but it is important to detect and correct them early to prevent amblyopia. By optical correction with spectacles, contact lenses, or sometimes both. How we diagnose a refractive error? It is mainly by retinoscopy and subject to refraction, and visual acuity and pinhole testing if the child is grown enough, and ocular examination by excluding other pathologies, and most importantly, cycloplegic refraction by preventing the eye from focusing and compensating for the optical errors. Once we detect a refractive error for the child, what are the factors we have to consider before prescribing the correct refractive glasses, correct power of the glasses? That is age of the child and visual acuity of the child if the child is grown enough, and type of refractive error, and most importantly, the child is having manifest deviation or not, that is esotropia or exotrophia. And one of the main thing I want to highlight is, do we have to correct all the refractive errors? The answer is no. Only the visually significant functional errors need to be corrected. And as we are all aware, prescribing glasses is very difficult in children because lack of subjective response, poor attention, and we need a very good cycloplegic refraction to catch the refractive error. And these are the American academic guidelines. I think Mr. Paradigal and the previous speakers showed this earlier. And as I told you, we have to consider several factors. The age of the child, here you can see less than 1 year, 1 to 2, 2 to 3, and 3 to 4. Then we are considering whether it is isometropic or anisometropic. And we are considering is myopic or hyperopic, and whether the patient is having manifest deviation or not. And the most important thing is that these are rough guidelines. We can't adhere 100% to these guidelines always. These values are generated by consensus and are based solely on professional experience and clinical impression. They are presented as general guidelines that should be tailored to the individual child. Specific guidelines for older children are not provided because refractive correction is determined by the severity of the refractive error, visual acuity, and visual symptoms. This is the same one, and this shows only the up to 2 to 3 years. And these are not the American Academy. These I got from a famous ophthalmologist from India. And I feel this is more or less practical to us as an Asian country. And this is showing up to the age of 4 to 7. And again, considering age of the child, myopic or hyperopic, isometropic or anisometropic. And here, they are considering exotropia and esotropia. And prescribing for older children is a bit different than the younger children. The visual acuities comes to play and symptoms come to play. In myopic children, usually come in with blurred vision for distance and sitting very close to the TV while watching and headache. Hypermetropia usually come in with astigmatic symptoms, convergent squint and headache, and astigmatism usually come in with astigmatic symptoms again and distorted vision, head tilting or turning. This is very important to talk to the parents and the child if the child is old enough. And once we diagnose the condition and once we want to prescribe the glasses, please inform the parents why we are doing this. And this is a precious time to wear the glasses full time and need for long-term follow-up because we need to prevent amblyopia. Because after this age, even though you are wearing the glasses 24 hours and you are occluding for 20 hours, we can't get the vision back. So please talk to them and spend some couple of minutes with them to just describe the importance. And as an encouragement, for example, for the mild hypermetropia and astigmatism, we can encourage them. This may disappear with time, so we can wean off the glasses. And actually, it will compliance will be very good with this encouragement as well as this understanding without doing what we are asking them to do. And at last not least, can the refractive amblyopia prevent? The answer is yes. By screening for the vision and refractive errors at the correct age, ideally age of 4 to 6 years before schooling. Thank you very much for your attention.